Well, thank you very much indeed. It's a pleasure to join you here in Amsterdam. I'm going to talk about an issue that confronts many of us on a regular basis, and that is how to handle a patient who has combined atrial fibrillation and coronary artery disease. Here are my disclosures. So the outline of the presentation is to first discuss the problem, define the problem. We'll review the key data from a number of studies, largely registries, look at guidelines for the management of these patients, and look at the potential for the new anticoagulant drugs to impact in the way that we deal with patients with this combined problem. Now, first of all, coronary artery disease and atrial fibrillation together is common. If one looks at coronary artery disease as a whole, it is present in 20 to 30% of patients who have atrial fibrillation. And when one has that combination, there is increased hospitalization with greater 30 and 1 year mortality. New onset atrial fibrillation is associated with a higher hospital and 30-day mortality as well as 1 year mortality. And it is prevalent and increasingly prevalent with increasing age. Antithrombotic therapy is indicated for both of these manifestations of vascular disease. It also occurs very frequently in patients with acute coronary syndromes, and as you can see here, there's a range of combined AF and ACS of between 2 and 21%. Now, since thrombosis and embolism is a common feature, it's not a surprise that antithrombotic therapy might be beneficial in both instances. But when you look at the pathogenesis of stroke from atrial fibrillation, it's largely a fibrin thrombus, whereas the thrombosis in coronary arteries is usually platelet-rich. And thus the approach to antithrombotic therapy is different, with anticoagulant drugs being the key in the prevention of stroke and atrial fibrillation, and antiplatelet drugs the main antithrombotic regimen in patients with coronary artery disease. This shows you an illustration of that in the study called ACTIVE-W, where antiplatelet drugs were compared with the vitamin K antagonist warfarin. There's a substantial benefit of the anticoagulant over the antiplatelet drugs, but when you look at the use of antiplatelet drugs following coronary stenting, for example, double antiplatelet therapy with aspirin and a P2Y12 receptor blocker is substantially better than anticoagulants. We don't have much in the way of prospective clinical trial data, but we do have an important registry and several registries from Denmark that have already reported on the issue of combined therapy. As you've heard, we will get information from the GARFIELD Registry on this particular problem, but as yet we have insufficient patients to come to any great conclusion. But if we look at the Danish registry, this is one looking at the risk of bleeding in patients on single, dual, or triple therapy with warfarin, aspirin, and clopidogrel in patients with atrial fibrillation. You can see that as one goes from single therapy with warfarin and aspirin, you can see quite a substantial increase in the hazard ratio of bleeding when one comes to use combined therapy, and in particular triple therapy, where the hazard ratio is 3.7, with warfarin monotherapy being the reference. So there is clearly an increased risk in bleeding when one adds additional antithrombotic therapy to the anticoagulants. Looking at patients with acute myocardial infarction, again from a Danish registry of 40,000 patients, you can see that there is the same feature illustrated with dual antiplatelet therapy in conjunction with vitamin K antagonists. It results in a substantial increased risk in bleeding complications with very little difference in all-cause mortality. Finally, an important registry in patients who are initiated on triple therapy with atrial fibrillation following myocardial infarction and a coronary intervention, once again from Denmark with 12,000 patients. You can see here that within a year, myocardial infarction, coronary death, ischemic stroke and bleeding events occurred in 18.5%, 5.6%, and 6.3% of patients respectively. But the interesting thing is that the conclusion of this study, looking at the interventions, was that triple antithrombotic therapy, which was the standard at the time, was no better, indeed, was associated with much greater rates of bleeding than the combination of warfarin plus clopidogrel, leaving out aspirin, as you can see here. The best regimen is this one with same rates of ischemic outcomes in comparison to triple therapy, but substantially less bleeding. So this raised the possibility that we could remove aspirin from triple therapy in patients with combined atrial fibrillation and coronary artery disease. And an interesting study from this country here, the WORST trial from the Netherlands and Belgium, was a randomized clinical trial looking at patients who had acute coronary syndromes, looking at dual versus triple therapy post-stenting. And as you can see here, there is a dramatic reduction in the risk of bleeding rates in patients who had dual therapy, that is without aspirin, but no major difference in ischemic outcomes. So I think this clearly demonstrates to us in a prospective way that there is much less bleeding in patients who do not take triple therapy, that is to say, with the aspirin removed. So what do we now recommend for patients who have atrial fibrillation and coronary artery disease? The cardiovascular societies have made an attempt, based on registry information for the most part, to come up with strategies to reduce the risk of bleeding. And if a patient has atrial fibrillation plus a coronary artery stent, for example, you can look at the patients that risk for stroke using the CHAD score here of 1, and if it is 1 or less, then no anticoagulant therapy is necessary and dual antiplatelet therapy is appropriate. If the CHAD score is greater than 1 and there is a high risk of bleeding, then the recommendation is usually for dual antiplatelet therapy, and if the risk of bleeding is low, then triple therapy is usually recommended. Now the question is, how long do you keep that triple therapy going? And here are guidelines written up by the European Society of Cardiology, looking at various combinations of different stents and bleeding risk in patients who have atrial fibrillation. And if we go over through these one by one, if you look at elective bare metal stenting, the recommendation is for 1 month of triple therapy, followed by 11 months of combined vitamin K antagonist plus clopidogrel, and after 1 year, the vitamin K antagonist alone. If one looks, for example, at patients who have acute coronary syndromes plus a stent, either bare metal stent or drug-eluting stent, the recommendation is for 6 months of triple therapy, followed by 6 months of dual therapy with a vitamin K antagonist and clopidogrel, and after 1 year to revert to the vitamin K antagonist alone. So clear recommendations, but not at the present time based on solid clinical trial data. If the patient has a high bleeding risk, both for elective and acute intervention, the recommendation is for 1 month only of triple therapy. And as you can see here, with an elective bare metal stent in this setting, the patient should have 11 months of vitamin K antagonist and beyond. For patients with a bare metal stent and acute coronary syndrome, the recommendation is for triple therapy for 1 month, followed by dual therapy for the remaining of that year, followed by vitamin K antagonists alone. So you can see quite clearly the recommendations are based on not only risk of recurrent thromboembolic events, but also for bleeding. So what about the new anticoagulant drugs? Do they have a role in this setting? We have a number of clinical trials which have evaluated the novel anticoagulant drugs, the factor X inhibitors, rivaroxaban and apixaban, and the thrombin inhibitor, dabigatran. Of these studies, the only one that had a successful outcome in terms of net clinical benefit was the Atlas II trial comparing rivaroxaban in 2 doses, 2.5 milligrams twice a day, or 5 milligrams twice a day, with most of the patients having dual anticoagulant therapy, antiplatelet therapy. And in this study, it clearly demonstrated that there was a reduction in cardiovascular death, recurrent myocardial infarction, and stent thrombosis, but with a small increased risk of bleeding complications. So the question is, can we now use a novel anticoagulant drug in conjunction with antiplatelet drugs in patients who have a combination of atrial fibrillation and coronary artery disease? And this will be addressed in a study called Pioneer, which is about to start, evaluating patients with non-valvular atrial fibrillation who are undergoing percutaneous intervention, where rivaroxaban plus clopidogrel is being compared with rivaroxaban, aspirin, and clopidogrel against the vitamin K antagonist with aspirin and clopidogrel. The outline of the study is shown here. And I think this will go a long way in answering the question regarding triple anticoagulant or antithrombotic therapy in such patients. So to come to a conclusion, what is the role of triple therapy at the present time? I've demonstrated to you what the current guidelines are, but it may have to be redefined because, as you're all aware, there are new P2Y12 receptor inhibitors such as prasugrel and ticagrelor, which are currently being widely used in the clinical setting. We know, based on the WORST trial and to some extent from the Danish registry, that triple therapy might not be needed. And there is a question of a new antiplatelet drug with a new anticoagulant without utilizing aspirin at all. And finally, I do think that the duration of the therapy does require to be better defined, and the new prospective clinical trials, and we will get also information from GARFIELD on this issue. So to conclude, the oral anticoagulants with vitamin K antagonists in addition to dual antiplatelet therapy does reduce the risk of recurrent ischemic events in patients with atrial fibrillation after stenting for myocardial infarction when compared to dual antiplatelet therapy alone, but increases bleeding significantly. Omitting aspirin in this context looks to be beneficial at the present time, but I think we do need future clinical trials to really evaluate this to a proper scientific conclusion, and the Pioneer study will go a long way to help us in this area. And finally, we will get lots more of information on this issue from the GARFIELD study as it progresses into the later cohorts. Thank you very much.